emergency room for those of you looking, and this is the long-term care track. Okay, so let's begin. First of all, let me say for all of our presenters today, everyone who goes through all the training to become a physician, thank you. When I was younger, I thought about it. I looked at the curriculum, chemistry, math. I said, no. But we have a lot of presenters here who said yes, and we have a chance to really just bask in their knowledge. So avail yourself to them. One is coming up for us right now. Let me introduce our speaker. My name is Nell Griffin. I am with Telligent, and I will be the moderator for this session. So let me introduce to you Dr. Teran. Dr. Teran is an assistant professor of medicine in the Division of Infectious Disease at the University of Nebraska Medical Center. He completed his medical training in Ecuador and completed a residency in internal medicine at the University of Miami, JFK Hospital, and a fellowship in infectious diseases at Boston University. He completed an additional year of training in infection control, hospital epidemiology, and antimicrobial stewardship at Boston University, Boston, VA. Teran currently serves as the medical director at the Nebraska Infection Control Assessment and Control Program and associate medical director at the Nebraska Antimicrobial Stewardship Assessment and Promotion Program. So he is an expert and he will tell you more about himself. Let's welcome.
Thank you, Nell, for that kind introduction. Can you hear me okay through the back? Perfect. Okay, so as Nell mentioned, my name is Juan Teran, and my work is very public health related. We help with stewardship in many settings, including long-term care, acute care, dental. So when they ask me to talk about stewardship during the transition of care, it's a little bit challenging. And I'll tell you why. I don't have any disclosures, but I do have to remark is that stewardship at the transition of care is a fairly new thing to investigate. Really, they started describing this in 2014, 2016. They started measuring antibiotic use. Most of the data is for acute care. Some of the data is for emergency departments. If you try to look for long-term care, it's very scarce to non-existent. I don't want to be negative, so I'm going to say there's a lot of opportunity to do research in long-term care. So we'll have to be creative, and we will have to adapt some tools from acute care and also from emergency department to apply it to long-term care. And also, most importantly, it's time to make connections. You have to collaborate with the hospitals you work with. Usually, this kind of care doesn't happen in a vacuum. Long-term care will have a strong relationship with some hospitals, with some emergency departments. As you know, Angela Tang mentioned today is the right day to look for collaborators. Give a call to your pharmacist at your site where you work the most, and I'm sure they will be open to do some collaboration with stewardship. This is important now more than ever because many of you received that email yesterday from CDC saying that about 20%, there was a 20% increase in multi-drug resistant organisms from pre-pandemic now to 2022. And Candida auris has increased 5-fold. So things are dire, so it's time to work together to find some answers. So the objectives, I want to make sure that I emphasize how important antimicrobial prescribing is at the transition of care. Most of the data that we get easily is from NHSN, and that's very limited to inpatient. So I'm going to make the argument that we have a lot of antibiotic that is prescribed after people leave the acute care hospital and the emergency department. We're going to assess if how accurate are we when we give antibiotics. Are we missing the target? I would say yes, a little bit. And what interventions can we do to kind of work with this transition care stewardship? So what is the background? If you think of only inpatient care, you're just looking at the tip of the iceberg. You're missing a lot of antibiotic use. And how do we assess that? One of the best places to do that is getting national data. And one of the programs that can do that is the VA hospital, the largest healthcare system in America, the largest EMR, electronic medical record system in America, so they can get some data. So here it's a very basic graphic, but you can see each bar, it's a hospital, it's a different VA. And in the light shade of gray, you can see what's given inpatient, but on the darker shade is what's given at the transition of care. So they looked from this data from 2014 to 2016, and they saw a lot of patients, 1.6 million visits to the VA hospital. And very surprisingly, I was very shocked when I saw that number. 47% of them receive antibiotic therapy. That is a lot of antibiotics. I would argue that I doubt that half of the patients going into the VA, they have an infection, but we are treating them as such. So of those who receive antibiotic therapy, of that 47%, 57% of them receive it only when they are inpatient in a hospital, but 42% of them receive it after they are discharged from the hospital. And that's what we want to capture. So here you can see that if you only look at inpatient data, you're missing about 39% of the antimicrobial prescribed in this transition of care. So you're missing a lot of data. So is that so? And if you prescribe a lot of inpatient, chances are that you're prescribing a lot of outpatient antibiotic therapy. Those are correlated. So is that it? Is that, do we have to look for that 40% that people are being prescribed at the transition of care? I would say we have a lot of limitations with that data. If you know the VA, they are missing OPAT, outpatient antimicrobial therapy, because the VA tends to contract that out to different systems. They also are missing the community living centers, CLCs, and they are missing the ones going into nursing care, skilled nursing facilities, long-term care, assisted living facilities. Those, they don't have the access to track that data. So even with that limitation, 40% of that antibiotic is being missed. I would say it's a lot more. So why does it matter? It's because, you know, we have been getting a push to get patients out of the hospital sooner. We know that people can get damaged if they stay for a long time in the hospital. They can get hospital-acquired infections. They can get multi-drug-resistant organisms during their stay. So there has been a push, and that's correct, for them to leave the hospital a little bit earlier, but they have to go somewhere. Not everybody is okay to go home. So about 11 to 15% of patients will go to long-term care. That's a lot of people. And that might feel a little bit nebulous sharing a percentage, but if you transform it to absolute numbers, that's about 5 million people going into long-term care, skilled nursing facilities, rehab. So that's about the population of Washington, D.C. moving into long-term care every year. And chances are that that is going to increase with time. So we have a big problem. And how much of a problem do we have? We don't have national data. We don't know how many patients that go into long-term care are receiving antibiotics the moment of their admission. But some hospitals, they've been trying to investigate, and that's the case with the Oregon Hospital Science University, OHSU. They wanted to see how much of those people going into long-term care are receiving antibiotics, and they checked for a couple of years, and they found of those 6,000 of them were going into long-term care, and almost 23% of them are receiving antibiotics. So when you work in a long-term care, a lot of those new admissions are going to be getting into your place with antibiotics. And surprisingly enough, they are using a lot of quinolones, despite our best efforts to reduce the use, because despite putting black box warnings into quinolones, it's very frequent that we use those antibiotics. We use cephalosporins and penicillins a lot too. So we know it's a lot of people going into long-term care, and the things that they get treated for are the common things that we tend to see. A lot of it is UTI, A lot of it is skin and soft tissue infection. A lot of it is pneumonia. Surprisingly, in this system, they also see a lot of endocarditis. That doesn't tend to be the case in many systems. But interestingly, of those 23% that go with antibiotic therapy into long-term care, they couldn't find an ICD code for infection. They couldn't find cultures in about 12% of those. And when they started digging through those charts, they saw that about 34% of those go with prophylaxis. So we know that there's a lot of antibiotic prophylaxis used in long-term care. And most people don't tend to finish those antibiotics. They just stay there for a long time, even if they're not doing more than increasing resistance. A lot of it is aspiration pneumonia. We know that many times we don't have to treat that. So there's a lot of work to do in that transition of care. And with this data, they decided to also run these regression analysis to see what's going on in terms of outcome. And those who go from acute care to long-term care with antibiotic therapy, they have a higher odds of returning back to the emergency department within 30 days. And they also have almost a 70% increase in getting a C. difficile-associated readmission or a visit to the emergency departments. So we know that they tend to go back to the hospital, and we know that they get more C. difficile. So that's an important thing to keep in mind. So we heard the numbers. We know that about 40%, 47% of those that go to the hospital receive antibiotics. We know that about 39% of those receive at the transition of care. Maybe about 23 of those going into long-term care receive an antibiotic during their discharge to long-term care. Are we giving it for the right reasons? Are we hitting the target or not really? You cannot talk about stewardship at the transition of care without talking about the work of Valerie Vaughan, the Utah University. She works in Utah, but she also collaborates with the Michigan HMS Consortium. HMS is the Hospital Medicine Safety Consortium. So it's about a group of 46 hospitals. And what they do is they track things like community acquired pneumonia and UTI, and they see how much overuse of antibiotic they have. So what did they do from 2017 to 2019? They wanted to see, how much overuse was related to these two very common diagnoses. And how you define overuse is three things that they wanted to check. One is unnecessary antibiotic use. The patient shouldn't have received that antibiotic from the get-go. And in UTI, that is usually asymptomatic bacteriuria. People are getting antibiotics just because they isolate a bacteria, and that's very common. In pneumonia, it's people that receive antibiotics despite having a viral infection. They have COVID and they receive an antibiotic, or they have bronchitis and they receive an antibiotic, or they don't have anything on chest x-ray or a CAT scan of the chest and they still receive antibiotic. That's the first rank that they did, those that didn't need antibiotics. The other thing that they checked is how long they're getting the antibiotic for. Is there an excess of antibiotic use? Mind you, this was 2017. They're being very conservative. At that time, having bacteria in your blood related to UTI was still an indication to give antibiotics for 14 days. We now know it's safe to do so for 7. Back then, it was also okay to give for pyelonephritis 14 days of cephalosporin or 14 days of Bactrim. We know now that we can give shorter duration of therapy and it's safe. And even being that conservative back then, there was still a lot of excess of antibiotics use. And the last one is using quinolones. That is a marker that we are using overly broad antibiotics. And if you're using quinolones when the patient is not allergic to antibiotics and you don't have another option, or the bacteria is resistant to everything else, then you're kind of missing the target and you're using suboptimal use of quinolones. So what did they find is that 21,000 patients with community-acquired pneumonia and UTI were found during that period of time. And of those, 74% received antibiotics after discharge. And that's the number that they wanted to track to see if there was overuse. And here's the number, it's shocking. About 49% of those with a diagnosis of UTI or pneumonia have antibiotic overuse. That was their primary outcome. They wanted to see how much overuse there was. And about half of those patients receive antibiotic overuse. And you can see on the graphic, each bar is a hospital and they tend to vary, but the most common thing to see on that green kind of shade is excess duration. We treat for too long. And that's an opportunity for long-term care. When they receive a patient, did they give too much antibiotics? I bet we can stop it a little bit earlier. So that's something you can work on. It's very interesting that UTI and pneumonia, they don't have the same reasons to have overuse. For example, in UTI, the most common reason is unnecessary use. Is what we see, and is that people get antibiotics despite being asymptomatic bacteriuria. They didn't need the antibiotics to begin with. But in pneumonia, is excess duration. They did have pneumonia, but they treated it for too long. Okay, so with that, we can know that there's a lot of prescription out there, and we're not doing the best job in terms of antibiotic use. There's a lot of overuse. So where does that come from? And I just want to touch very briefly on this, because this could be a topic on its own. When you think about why we prescribe so much antibiotics, there's two things that we should be thinking about. One is an organizational context, and the other one is why, as a person, I prescribe more than the average person. So we start with organizational context. This was also Valerie Vaughn. She's very active on this realm. And she wanted to look at hospitals that had excellence in stewardship. And she recruited 3 hospitals from the Michigan HMS Consortium and 4 hospitals from Utah. And she wanted to divide them according to tertiles, those that do a very good job at antimicrobial prescribing, those that are kind of in the middle, and those that do kind of a bad work at doing that. And she wanted to identify things that are common between those that do a very good job. And what she found is that stewardship excellence is related to, first, knowledge and comfort with stewardship. Second, interprofessional dynamics and group cohesiveness. Then we have tools and infrastructure. And finally, we have the support of an ID physician. So let's break down a little bit the data that she found. In terms of knowledge, a hospital that have locally adapted guidelines tends to do a little bit better. They have applied the guidelines that we have available nationally, and they put it to their hospital. They know their antibiogram, they know how people use their antibiotics, and they target their population very well. The other thing that she found interesting is it's not so much that the people that are in hospitals that prescribe a lot of antibiotics are new. They really have the same time of practice, but rather is that the better hospitals have a little bit more training in terms of the stewardship pharmacists and the ID physicians. So really that extra education in stewardship, it really pays off at the end. In terms of interprofessional dynamics and group cohesiveness, really, if you don't have a hospital that respects your stewardship work, chances are that things are not going to go very well. You can see that there's a correlation between am I respected as a pharmacist, between my pharmacy colleagues and my hospitalist colleagues. And if you are not very well respected, your ranking tends to go low. If they see you as the antibiotic police, they won't take your advisement. So really, that face-to-face interaction is really important. You have to cultivate those relationships. There's a lot of work out there in how to deliver those recommendations so they don't feel like you're kind of punishing them. You're really working with them to get the best outcome for the patient, and that's what you gotta work with. People that tend to work with what they call handshake grounding, they do a lot better if they go in person and talk to the providers rather than trying to call, he's not paging back, and I didn't get the recommendation in time. Chances are that, that's not going to go very well. In terms of tools, If you have institutional guidelines, especially for the pharmacy team, that's going to be very important. Some hospitals have developed the med to bed, um, approach that they give the medication before discharge. Also, in your EMR, if somebody, for example, has pneumonia and you're going to treat it for 5 days and they are on day 4, if your EMR has the option of finish 3, 7, 10, and 14 days as the automatic voting, people are going to click that. They're not going to manually type 2 more days of antibiotic. They're going to click the automatic and they're going to give 6 because that's close enough. So you really got to work with your IT department and EMR to make sure that people are making the right decisions. If you put something automatic, people are going to click on it. And finally, if you have an ID physician that has enough FTE to support your program, that's going to be important. We know that there are programs that have ID physicians, but it's all clinical work and no stewardship. They really don't tend to have the time to support their teams in terms of stewardship activities. So in all, the organizational context matters a lot. What about individual prescribing behaviors? Why do we prescribe the way we prescribe? And that's a very, very complicated question. And there's a lot of psychology behind it. I'm just going to touch very quickly. Pat Cross-Carey, he's from Halifax in Canada. He has been working for many, many years in analyzing why do we have these cognitive biases. And he's a proponent of what's called DPT, the dual process theory. And basically what he says is that we have a type 1 reaction and a type 2. Type 1 is kind of an automatic. I've seen this before. I know how it goes. So I see a patient's coughing and then I see an infiltrate, it's pneumonia, and I know what I give. I do that very quickly. Most of the time it's effective. It's very quickly, it's very efficient, but it's very susceptible to bias. Type 2 thinking is more analytical. You kind of stop, you assess, but that takes time. And we don't do that often. We tend to favor type 1 processes. And the way that we get these type 1 processes is from different ways. Sometimes it's kind of hardwired into our process. As people, we tend to sometimes be overconfident in the type of decisions we make. Sometimes it's an emotional process. Let's say that I trained in a hospital that was mainly for cancer patients, and I saw these tragic cases. When I go to a different system, maybe I'm a little bit overly conservative with my antibiotics because I've seen that before. I have that fear that they don't do well, even though I'm in a different context, and I'm not being conscious of that decision. I'm making that a decision. Sometimes it's overlearned processes. We've seen that we trained with somebody who was prescribing 10 days for pneumonia, and I kind of picked that up. And I'm not thinking again, when I prescribe my antibiotic, I just learned that behavior and I just continue. And the other one is implicit. I don't even notice I did that, but I just picked it up. Let's say like the talk from Dr. Walker that Black community and minorities are getting more clindamycin, more vancomycin, less cefazolin. Chances are that people are not going out there and saying, how can I make my day a lot of inequity? How can I mess with this patient? They are not doing that, but they just saw how they treat Black patients, and I kind of picked that up, and I'm giving more clindamycin, even though I'm not doing that consciously. I like the way that they phrase what a bias is a predictable deviation from the rationality. So it's a systematic thing. So I'm not conscious about it. So that's a very difficult thing to break. And examples of that is, for example, when a patient is handed to me and they say they have pneumonia, I just can assume that's the case. There's a diagnosis momentum. We kind of assume that they did the right thing, they gave me the right diagnosis, I'm just going to continue the treatment. And I don't think that, okay, maybe this was heart failure, and maybe I should stop antibiotics. I now have more information. I can switch my diagnosis. Maybe the diagnosis was suggested by the patient. I always get this bacterial sinusitis. Only amoxicillin really helps me out, and I can listen to him. even though it was a viral disease and I could have stopped the antibiotic. Or I just take the first diagnosis that comes into mind. I see somebody, and they say it's burning when I pee, but I didn't investigate, and it was a kidney stone and not UTI. I just treated with 5 days of antibiotics unnecessarily. So we have a lot of these cognitive biases. There have been more than 100 cognitive biases found, more than 12 affective biases seen in the literature. So how can we fight this? First is knowing that there's a bias. The awareness of a bias is the first step, and that's where the stewardship team really comes into action. Most people don't think that they overprescribe antibiotics. Somebody has to tell them, hey, benchmarking, you cannot prescribe more antibiotics than some of the other team members. That's a very powerful thing to do. And some people have been doing these kind of report cards so people are aware of how they do it. That really even happened to me when I was a fellow. I was an infectious disease fellow. I was interested in stewardship. I gotta be the best, one of the best antimicrobial prescribers. And when my pharmacist told me that I was a little bit conservative, oh my God, it was shocking. It was a dagger to my heart. But when the shame and the anger subsided, I was like, maybe I can do a better job at transitioning to oral therapy a little bit quicker. Maybe I can shorten the duration of therapy. But if somebody didn't tell me that, I was not going to be aware of that. So in long-term care, that's where you got to do some of the work. Let them know that there are over-prescribing antibiotics. You got to be motivated to change, and sometimes it's showing the data. We have a lot of prescription. That is why we got to make a change. We got to be aware of the direction of the magnitude of the bias. So sometimes the stewardship team almost have to be a therapist and provide reassurance in order to slowly start peeling off these biases. Sometimes it feels like Sisyphus pushing that rock and not going anywhere. But if you continue doing the work, you're going to see some changes. So that was a little bit of some a small excerpt on why we prescribe so much. So let's talk a lot about what can we do for stewardship interventions, especially the transition care. So we'll talk about some clinical vignettes and some interventions. So different approaches to do this. This one was from Denver Health. This is Yogo and collaborators. They decided to put some institutional guidelines. They created guidelines for skin infections, for UTI, for community-acquired pneumonia, for COPD, and they did audit and feedback. So what did they find? And it was mainly that the ID pharmacists trained the other pharmacists to do this work for them. And when they analyzed what happened, they selected 300 charts from before they did this and 200 after they implemented this. And their broad gram-negative antibiotic use decreased from 51% to 40%. The total duration of therapy was not as statistically significant, but you got to know that this is not a big sample size, but the work is really making some changes. So then when they did a subgroup analysis, analyzing those with community-acquired pneumonia, UTI, and skin infections, they saw an even greater change going from 50% gram-negative broad coverage to 35%. And this was even closer to being statistically significant for duration of therapy, decreased duration of therapy. So they did see an improvement. They just didn't have the numbers to prove it as statistically significant change. This is another example. This is from California, from Santa Barbara. So this one is from an ID pharmacist, and they implemented a transition of care pharmacist. The sole job of this pharmacist was to look at the discharge orders and make sure that they are correct. So they have a steward that provided education. They had the guidelines from IDSA. They defined what is appropriate, and they gave handouts to all the hospital, to the hospitalists, to the medical directors, And whenever somebody placed an order for discharge, that went immediately as a stat order into the pharmacist. And what they found when they analyzed pneumonia, UTI, and skin infection is that the inappropriate prescriptions, they declined from 52% to 34%. That was a big change, and that was statistically significant. So if you have a pharmacist that can dedicate most of their time to do this, you really are going to get your yield on this one. And you can see the different areas that they improved. With antibiotic dosing problems, almost non-existent after they implemented this. Treatment duration decreased, the antimicrobial selection was better, and the antibiotic not indicated, it really decreased a lot. So that is one approach. The other one, this one is from New York Upstate University. They also had an ID pharmacist to review all the antibiotics that they went into discharge. And that pharmacist, if they thought something was erroneous and could be changed, they called the provider and they switched the medication, and they found the acceptance to be quite good. So if this one, they didn't compare like a pre-intervention and post-intervention, they just showed the numbers of how much work they did. And you can see which antibiotics are the most commonly prescribed when they did this work. It was mainly beta-lactams, but again, quinolones showing their ugly head in every single list. We overuse quinolones, and the reasons that people were prescribing, a lot of prophylaxis, a lot of UTI, a lot of pneumonia. So in that work, from 800 prescriptions, they found drug-related problems in about half of them, a little bit more than half. And treatment duration being too long was about a third of those problems. And there's no indication for a drug. It was almost 15%. So those were some of the approaches that some people had in acute care. So let's put this into context and let's talk about a case. So we have this is your typical case in long-term care. You have a 72-year-old female. She has a history of recurring UTIs, and she develops delirium. She's very, she's not with it. Her blood pressure is kind of soft. You don't feel too comfortable keeping the patient in the long-term care. On physical exam, she kind of grimaces whenever you press the belly where the bladder is located. You know that she had prior infections with multi-drug resistant organisms, and her last infection was with an E. coli, that it was an ESBL. So she was sent to the emergency department where she was given some IV fluids. A urinalysis shows pyuria and bacteria. She was given 7 days of levofloxacin, and because she responded quite well, she was sent back to her skilled nursing facility. She completes the treatment. She feels great. Was that a successful outcome? I would say no. Let's say that this happened. The culture was pending. Nobody reviewed it in the emergency department. It was a pan-susceptible proteus. It was an excessive duration. It was the wrong antibiotic. Nobody followed on that culture. And that happens way too frequently. We know that they do cultures, and the long-term care facility just doesn't know about them. How can they act if they don't even know? So what have some people have done? This is from Wu in the American Journal of Emergency Medicine, and this was done in Cleveland in 13 emergency departments. So they had somebody from pharmacy reviewing everything that was pending, and they gave a call back. If something was pending, they gave a call back. If they needed antibiotics, they prescribed them. If they needed to stop them, they did. If they need to switch the medication, they did. And most importantly, also in the discharge summary, they included the information and they gave a follow-up number. So that's an easy thing to do. If you have somebody, you in your long-term care, you have an emergency department that your patients tend to go to that place, give them a call. Hey, in your discharge summary, can you put if something is pending? And do you have a number that we can call to see those cultures? That would make a world of difference if you can switch those antibiotics. What did they do? They found that in terms of microbiology, 50% of those were urine cultures and 15% were sexually transmitted infection results. And you can see if you go to the urine, you can see that 28% they started therapy, in 16% of them they discontinued therapy, in 39% they changed the medication. It turns out that if you have more information, you can do a lot more. But if you don't have that information, you're very limited. So we have another case. We have a 68-year-old man with Parkinson's disease. He has a ground level fall, complicated with a right tibial fracture. He has surgery. They put some plates, they put some screws. And, he was seen by PT, by OT. They said that he can probably go home tomorrow. But he's kind of short of breath. His saturation is between 85, 89. You do your chest x-ray. It kind of looks like there's some fussiness over there. He's given 10 days of amoxicillin clavulanic acid. He's sent to the rehab facility. Problem is, the patient gained 7 pounds. He had a lot of edema in the legs. He didn't have a fever or leukocytosis. He received 2 units of blood before the surgery and was given IV fluids for 3 days. It was heart failure, and that happens way too often. There's some data that 30 to 40% of patients with heart failure, they receive an antibiotic therapy, completely unnecessary. And that's a great point where long-term care, their medical directors, their geriatricians, their primary doctors, they know the patient. They kind of know if he's looking a little bit more bloated than usual, he looks more volume overloaded. So they can do this. They can do the 5 Ds of antibiotic stewardship. They can see if the diagnosis is right. They can see if the drug is needed. They can see if the dose is right. They can see the duration is appropriate, and they can de-escalate. In this case, they could say the diagnosis is wrong. This patient has heart failure. I'm going to stop the antibiotics. So you got to empower your providers in your long-term care to make the right choices, and don't choose that diagnosis momentum of, they told me he has pneumonia, I'm going to continue the treatment. So what's on the horizon? Again, Valerie Vaughn, she kind of looked at those hospitals in Michigan, and she found that most of the implementation of things in stewardship, they can be divided into critical infrastructure, into broad interventions, or very specific interventions at the transition of care. Things like critical is having a stewardship team, having IT support. Broad interventions are having timeouts, having auditing and feedback, and having a discharge-specific intervention is, for example, de-emphasizing quinolone use, or having a pharmacist that works in when they have a discharge order. And it turns out that she thinks that on tier 3, you're going to get your most yield, but it tends to be kind of a costly thing. So she kind of analyzed hospitals, and she saw that the more implementations you have, doesn't matter the tier, the more you have. And she gave 3 points to those in discharge, 2 for the broad spectrum, and 1 for the critical. But you kind of can choose which interventions you do, as long as you have enough of them to kind of reduce antibiotic use. And she saw that between the hospital that had the least interventions to the hospital that had the most, there was a 45 predicted reduction in overuse in antibiotics. And she found that a tier 1 implementation can reduce your risk of overuse at discharge in about 4%, but a tier 3 intervention might decrease it in 12%. But if your hospital cannot do a tier 3, maybe you get 3 or 4 tier 1s, you can do the same kind of activity. So you can choose the way. There's no one road, and that's kind of why she framed it the road framework. And what she's going to do is she's going to do a parallel cluster randomized trial using that road intervention versus your usual antibiotic stewardship, and they're going to see how they do. So we kind of went through a whirlwind of information. We kind of know that if you only see inpatient antibiotic, you're kind of missing the whole thing. You're only looking at the tip of the iceberg. We kind of talked about why we prescribe the way we prescribe, and we kind of saw some interventions that you can use to decrease your overuse of antibiotics at the transition of care. So some take-home points. A lot of antibiotic is given at discharge. You saw that those numbers, so you got to be mindful of that. Prescription practices don't happen in a vacuum. You got to take the context of the organization. You got to see why the prescriber is prescribing the way they do. There has to be collaboration between the emergency department, between the acute care, between the long-term care facility in order to improve outcomes. Nobody is an island. You're not going to improve on your own, especially when it's transition of care. You can focus your interventions on discharge, or it could be broad, and you can combine. There are multiple pathways that you can make an effect in your hospital. So I hope this encourages to use some of those interventions and improve the antibiotic use in your facility. Make those connections here, talk to people, work with each other. You're gonna make some headway, I promise that. So with that, I'm happy to take any questions. Thank you.
For your presentation. My name is Juan. I'm one of the infection preventionists at Chicago Public Health Department. My question is well, with knowing all of this information, with cognitive bias and all this research out that's showing over prescribing antimicrobials, why is it not being incorporated in why is it not standardized like in the trainings for providers with prescribing privileges?
That is a great question. It should. It definitely should. I think the fact that we sometimes don't think about psychology being into effect into stewardship, it's something that is not ideal. One of the things that my program did and I'm so glad they did as a fellow, my workroom, the stewardship pharmacists seated in the same room. So they kind of talked to me about my biases, the way I prescribed. And I think from that collaboration, you can do a lot of that. But yeah, it should be a standard. It should be something that we are aware. The more aware we are, we can start that processing of de-biasing and start acting more with that type 2 kind of thinking that is more analytical. So yeah, absolutely, it should be. Sadly, is not currently part of the standard curriculum.
Yeah.
Hi, I hope that we also acknowledge cost. Cost is a definite obstacle that I face specifically now with the medication that is for COVID. And so, when it's appropriate. And so my question is, how, as long-term care, do we also deal with the not necessarily the non-formulary or doing, the approval, but mostly when it's, okay, this is a little bit sensitive, but this is more sensitive, and this is the best choice, but it's $300 more, so we're just gonna go with the cheap stuff.
So that is a great question. So in that, you have to do a little bit of a cost effectiveness analysis. Sometimes even though it's more expensive to begin with, the less adverse events you have and the less overuse you have, is at the end is going to be cost effective. If you can show them how much antibiotic overuse you have in your facility, and if you cut that, it's going to save us, let's say, $75,000. Then, being 300 more for medication, it doesn't feel that bad when you're saving so much on other things. So we know antibiotic stewardship is cost effective. So the thing is talking to leadership and proving that to them. Sometimes showing numbers is the best way to kind of get buy-in. So even though it's a little bit more expensive to begin with, these type of interventions at the very end, they tend to be cost effective and better for the patient. Absolutely.
So, my question about this study that you mentioned about is when we are treated with level for UTI, clinically responding to the antibiotic, sent back home or continued on level point, but culture showed a different, culture showed an organism which is not susceptible. At that point, clinically wasn't indicated to change the antibiotic because there was a clinical improvement in the symptom and patient was responding.
Yeah, that's the very point of that case, that knowing that culture would give you the chance to, for example, go to amoxicillin and just treat it for that, or go to Bactrim. And that way you are first not using a quinolone, second using less days of antibiotic therapy. So the more information you have, information is power in this type of things. But the problem is that way too often we see that nobody follows up with that culture. And that is the problem. So that's why we emphasize to talk to the emergency departments, talk to the hospitals, make sure somebody writes down on the discharge summary, this is pending, this is the way you call us back, this is how you can get some more information.
The follow-up on the spending culture was one of the problems the roundtables discovered.
My name is Teran. Infection control is a major attack. Will there be a violation of overuse of antibiotics to each nursing facility? And what role does the Department of Public Health play to impose to the nursing facility if we have overuse of antibiotics? There's a lot of overflowing data, and I believe that the nursing part, including the infection preventionist, is a limited authority over the medical director. And this is the struggle. The data only speaks to us that there's an overflowing use of antibiotics. What is the role of the Department of Public Health?
So that is a great question, and I can tell you what we do in Nebraska. I work with Nebraska ICAP and ASAP. So we are partners with the state public health department. They contract with us, so we do the infection control assessment and we do the stewardship work. What we do is we have these data use agreements of memorandums of understanding, so we can get your data. And what we do for you is we benchmark some data. So we give you a report and we tell you to the facility, hey, you're using way too much quinolones, you're using too much third generation cephalosporins. So there's no violation in terms that there's no specific data from the patient, but we give you an aggregate of things that are happening in your facility. So that's how the public health department can help you, is getting that information aggregated. And if you have a data use agreement, there's no violation. So I encourage you to work with the Illinois Department of Public Health. The more data you have, the better decisions you can make. At the end, Illinois Department of Public Health is there to help you.
Just to further clarify your question, are you asking public health to give more citations? It's your call and they're on the outline right now. So, one of our participant facilities in the medical department, very, very active, people are supposed to be here today that had an emergency, and we had some posters with them, active participant in the Palace Collaborative, and that's how we started our collaborative with them, where the health department did extend a citation for an antibiotic used, where the year coding in the EHR and MDS did not meet the criteria. So there was a citation given for unnecessary medication.
So it does, and that was further complicated, because there was another evidence-based criteria used, by the facility and the clinicians. But yes, it can, more and more, career guidance, when it comes to regulations around stewardship and infection control. It is becoming, more and more clear, and the surveyors are getting the hang of it as well. And as you know, a lot of this education, comes through the, health department, safety and quality, wing, and then there is the OHCR, which is the surveillance certification, and I just think that, that's my bias, I think that the department is doing well. Not that, I have a bias that we have a contract with them, but as a medical director, I think, a lot of these surveys, are a lot more, educational and I'm just using, for lack of technical, fair when it comes to, work around stewardship and infection control, given all of us, survived the pandemic together and the stories we have from that. But great question.
Hi, my name is Dr. Sushila. Can you please comment on the long-term use of antibiotics for like recurrent infection? I've seen like people diagnosed with recurrent UTI even on long-term antibiotics, recurrent cellulitis, and now I have a lot of recurrent sleep as well. So how long should we keep them on, and considering that they will be having recurrent cellulitis in long-term? I was curious about that.
Yeah, absolutely. That is a complicated question in terms that it depends on the agent you choose. For example, if you use nitrofurantoin, probably 5 days for women and 7 days for men is appropriate in terms of UTI. Bactrim, it used to be for pyelonephritis, 14 days. Now we know 7 to 10 days, according to how quickly they respond to treatment, is enough. Quinolones, ciprofloxacin was studied for 7 days in pyelonephritis, and levofloxacin, the selling point was that they could be used as 5 days. So what I would say is, there are guidelines that we can use. For example, the IDSA guidelines, that they are very soon to be updated. I'm sure the Illinois Department of Health has their stewardship website that they have recommendations. Northwestern has the ADSP. Us at Nebraska, we have Nebraska ASAP with best practice recommendations in terms of duration.
Sorry.
No, of course.
I think the question is chronic suppressive therapy.
Chronic suppressive therapy. So there is a role of chronic suppressive therapy. Usually we call it as the last choice of therapy that you should be using. In terms of things, especially you're going to see recurring UTI in women. That tends to be the most effective population. Methenamine heparin, it's an option as a non-antibiotic and antibiotic-sparing suppression therapy that you can use. The data has been mixed between cranberry juice. There's data, for example, in elderly women to use vaginal estrogen that can really decrease the number of UTIs and the amount of bacterial colonization. So we tell people that antibiotic prophylaxis should be the last choice in your toolbox. Many times you can get away with something else: vaginal estrogen, methenamine, cranberry, hydration. If there's some urological abnormalities, talking with urology to see what they can do. Antibiotic really should be the last choice.